name is Dr. Daniel D. Sewell. I'm a geriatric psychiatrist and a member of the faculty at the University of California, San Diego. I am a professor of clinical psychiatry as well as the medical director of the UC San Diego Senior Behavioral Health Program. In addition, I co-direct our Memory, Aging, and Resilience Clinic, and currently I am serving a one-year term as the president of the American Association for Geriatric Psychiatry. Now I'd like to spend a few minutes talking about the differential diagnosis of behavioral symptoms in a patient with dementia illness. There is quite a long list of possible explanations for changes in behavior in a patient living with dementia. And that list includes the emergence of a new medical problem, the potential for a pre-existing medical problem to have worsened. The list includes the potential for behavioral symptoms being triggered in some way by suboptimal prescribing practices, which include polypharmacy, but include also many other potential forms of suboptimal prescribing. In addition, the differential diagnosis of behavioral symptoms includes the emergence of a new psychiatric condition, the possibility that a pre-existing psychiatric condition has reemerged. In addition to that, we have to be concerned about the impact of drugs and alcohol. We are aware that sometimes family members naively assume that it's okay for their loved one with dementia to continue to use alcohol in a way that they may have prior to their diagnosis of dementia. We occasionally will see a family member with the best of intentions using alcohol or some other substance in a therapeutic way, for instance, perhaps offering liquor at bedtime in order to address an issue with initial insomnia. Sometimes when these patients come to the hospital, if we're not careful, we may overlook history that's very pertinent. For instance, perhaps the person has been consuming alcohol on a daily basis, and so now what we're seeing in the context of a hospital admission is some form of alcohol or sedative hypnotic withdrawal. So all of these have to be thought through when a clinician is asked to assess behavioral symptoms in a patient living with dementia. Often, if behavioral symptoms are being triggered by underlying medical illness, what we're actually seeing is delirium superimposed upon the pre-existing dementia. Now, it's true that in a very late stage of dementia, patients may be in a rather continuous delirious state because the degree of brain injury has been so great that they really can never escape or recover from delirium. But for a large part of the course of illness of a patient living with dementia, it's possible that they can experience a sudden change due to delirium, change in behavior triggered by delirium. So when we collect history about behavioral problems, one of the things that we focus on is the onset of the change. The natural history of most dementias is that they are slowly progressive neurodegenerative illnesses. So we really don't expect radical change in behavior from 1 hour to the next or 1 day to the next. What we expect is that from month to month, we are seeing gradual loss of function and gradual change in behavior. So when we interview someone or when we interview collateral historians and we get this history that yesterday the patient was just fine, but today the patient looks dramatically different, that's a big red flag that what might be triggering the change is an underlying medical illness that has authored delirium. As I'm sure most of you understand, delirium is the term that we use to describe change in brain function related to acute medical illness. The hallmarks of delirium include abrupt onset, but also can include changes in just about any other domain of brain function. So people with delirium, they have sudden onset of psychosis, We often particularly think about visual hallucinations as a hallmark of delirium, but they can have other changes as well, including changes in sleep-wake cycle and even changes in coordination and the ability to speak clearly and also to have organized thought. Patients living with dementia may experience various forms of psychosis. And the nature of the psychosis can often be very helpful in terms of sorting out the differential diagnosis. In general, a patient with Alzheimer's dementia is not going to be at risk of having visual hallucinations. So when we see someone with Alzheimer's dementia presenting with visual hallucinations, it really suggests that we are witnessing a delirium superimposed upon the dementia. There are other types of psychotic symptoms, however, that are very common in a patient living with dementia and are really not indicative of delirium. For instance, in patients living with Alzheimer's dementia, by far the most common form of dementia, we know that they are experiencing profound deficits in short-term memory. And because of these deficits, we often see a unique type of delusion emerge, a delusion that we can connect back to the fact that they're having difficulty with short-term memory. I'd like to now spend a few minutes talking about common delusions in patients living with dementia of the Alzheimer's type. What you'll notice about all of these delusions is that they share something in common, and that is that they are connected to one of the most prominent and primary cognitive deficits that these people are experiencing, which is rapid forgetting or profound short-term memory loss. Some of the more common delusions that we would see in this clinical context include the delusion of theft. The issue here is that the person, unfortunately, may not remember where certain things have been placed, like a wallet or a purse. But many people living with Alzheimer's dementia are also living with this condition that we call anosognosia, or the inability to remember that they don't remember. And because of that, when they misplace something, they don't conclude that it's been misplaced, they conclude it's been stolen. So delusions of theft, then, are a very common type of delusion in someone living with Alzheimer's dementia and experiencing rapid forgetting. There are other delusions, though, that we think of as being typical of people living with Alzheimer's dementia. And another delusion that we might see would be a delusion of infidelity. And we believe that this delusion is likely to arise because the short-term memory deficits actually interfere with the person tracking time. So a very common scenario would be that a person with early to mid-state Alzheimer's dementia is at home and a caregiver says, "Hey, I'm going to run to the store for bread and milk. I'll be back in 30 minutes. But because they can't remember when that person left the home, because they can't really track how long that person has been away from the home, in the mind of the person with dementia, it seems as if their loved one has been gone a long time. And then their imagination kicks in, and they begin to wonder, why has this person been gone for such a long time? And then they begin to suspect the reason could be that the caregiving spouse has become unfaithful and is actually spending time with someone else. So that's another type of delusion that we really often see in someone living with Alzheimer's dementia. Another type of delusion that we often see in someone living with Alzheimer's dementia and rapid forgetting is the delusion of abandonment. And the issue here is that the presence of rapid forgetting prevents that patient from remembering that loved ones have recently visited. And then they begin to feel as if they've been abandoned and that no one has come to see them in the hospital. This particular type of delusion often responds quite well to behavioral interventions. On the inpatient unit where I work, in each patient room, we have a quick erase board. And if we identify a person with Alzheimer's dementia who is experiencing delusions of abandonment, what we'll ask the loved ones to do is that whenever they visit, we hand them a quick erase marker, and they can, in their own script, leave a message on that quick erase board saying something like, "Hi, Mom, I visited you this morning. I'll see you again tomorrow." What makes that type of intervention especially effective is that people living with Alzheimer's dementia are experiencing, for the most part, a phenomenon that we sometimes call first in to the memory, last out. And what we mean by this is that when someone lives with Alzheimer's, it's as if they're moving back in time. So in early phases of the illness, they may forget what happened a few hours previously, a few days ago, but the further into the illness they go, then they are actually moving back in time because they have no memory for the past 5 years or the past 10 years. Interestingly, for those of us who have raised children, we identified early on what their penmanship looks like, what their script looks like. So I might not remember what happened a year ago, but I'll remember 30 years ago what my son or daughter's handwriting looked like. And so when my son or daughter leaves me a message written in their own hand, it has credibility, it has believability. And so for someone with delusions of abandonment, if we can connect them to a written message from a loved one, and if they recognize that script as being their son or daughter's or husband's or wife's script, then just seeing in writing that they had been visited that day often goes a long ways towards comforting them and diminishing their anxiety and correcting this fixed false belief that they've been abandoned. Another type of delusion that we sometimes see in individuals living with Alzheimer's dementia is the misidentification of family members. And this also connects to that phenomenon, first into the memory, last out. So if I'm in a mid-stage of dementia, the last 20 or 30 years of my life may not exist in my memory. In fact, I may not remember what my spouse looks like at this moment in time because my most recent memory of my spouse is when they were 30 years younger. If this is happening for someone living with Alzheimer's dementia, then what can happen is one of their adult children may be misidentified as their spouse because that adult child may have such a close physical resemblance to their spouse when their spouse was 30 years younger. Finally, another delusion that I can spotlight that we sometimes see in someone living with dementia is the idea that their house is not their home. The place that they're currently residing is not truly their home. This again relates to the phenomenon first into memory banks, last out as one moves forward in dementia illness of the Alzheimer's type. So what can happen is that even though someone has been living in a house here in San Diego for 20 or 30 years, their memory of that home may have disappeared from their memory. And so the home that they're remembering might be their child home in some other part of the country. And so when they're in the home that they've been in for the past 20 or 30 years, it just isn't identified as their home.